Good morning, everybody. So, for those who don't know me, my name is Stephan Busque. I'm originally from Montreal, and I'm Mary. And I trained in transplant at the CPMC when Carlos was the director, and went back to Montreal for 6 years. And Carlos called me back to have a look at the job here, and that's 2001. And it's been like a privilege to be here since that time. My interest in academic interests has always been on the improvement of clinical immunosuppression. So when I came here and I was able to join the team that look into tolerance, which to me is the ultimate approach to clinical immunosuppression. What better drug than no drug? So it's been a privilege to be part of that team. And today, I will share with you our experience, our success, our struggles, and our vision for the future. I speak today in the behalf of all the co-investigator people who have participated with that effort, and some of you are in this room. I'd like to do a little bit of introduction so you can benefit a little bit more from knowing what we are doing clinically. So, congratulations on your transplant. This is the medication you have to take for the rest of your life. What is a bit sad about this is that I took that picture in 2000, and if I'd taken one at the clinic yesterday, it would be pretty much the same. And some of you have probably seen a bit in the middle of the last year, the essay by Amy Silverstein, who a few months before her death, after 2 heart transplant, and she made a plea about trying to have more research to reduce the burden of immunosuppression. She was extremely grateful to have 2 heart transplants, but she died from the complication of the immunosuppression. She died of a lung transplant, a lung tumor, and advocating for the advancement of reduction of immunosuppression. So these drugs are very good. In the United States, if you're after discharge from your transplant, most patients will take 3 drugs. Number 1 is tacrolimus, which is probably the most efficacious. Mycophenolate mofetil, in addition to tacrolimus, has contributed to reduce the rate of rejection significantly, enough that some patients can have their maintenance immunosuppression without prednisone. And these drugs have resulted in the improvement of outcomes after transplant, and significantly. At 1 year now, if you get a living donor transplant, you expect to have close to 100% success. Deceased donors a bit lower, 94%. The problem is that there's not been much impact down the road. At 10 years, more than half of the patients who receive a deceased donor transplant would have lost their transplant. It's better for living donor transplant, but it's still a chagrin to see that more than 35% would have lost this gift of life. So there's multiple causes to these graft loss, and still remains the incomplete treatment or prevention of rejection, or the toxicity from the drugs, leading to patients dying prematurely, even with a functional graft. So if you compare just a living donor transplant, as opposed, the donor will continue to do all his life without any risk of graft failure or native kidney dysfunction. And this is the gap that we have to try to make smaller. Can you make the recipient recognize the graft as his own, which we call tolerance, and then have better long-term outcomes? And this is the goal of immunologic tolerance in transplantation. And often we think more about the medication, but the most important impact of being tolerant is the prevention, lifelong, of rejection, of any type of rejection. Acute cellular humoral rejection or the insidious chronic rejection that is difficult to detect until it's too late. But also the elimination of these drugs will have significant impact. They have side effects and complication. As we have mentioned, infection, diabetes. If you develop diabetes after transplant, you reduce your outcome by 40%. Cancer, hypertension, hyperlipidemia. These are all associated with cardiovascular risk, which may shorten the life of the recipient. So taken together, immune tolerance has the possibility to reduce the premature graft loss, but also the premature death of the patient. So since the first workshop in tolerance, we have every couple of years, the goal has been we should work towards a kidney for life. Because as you've seen, if you're young, you may need 1, 2, or even 3 kidneys during your lifetime. So what is the definition of tolerance? So we can read here this definition that has been brought up by Dr. Strober from Stanford and Dr. Sachs from Boston in 2010. So it's the specific absence of a destructive immune response to a transplanted tissue without immunosuppression. So the clinical operation to see if the patient are tolerant, you need to demonstrate that you have complete withdrawal of immunosuppression followed by no evidence of rejection of the transplanted organ for more than a year. And you need to prove that it is also specific as opposed of immunosuppression that is broad. So in animals, you can do a third-party graft. Of course, in humans, you cannot do that, but you can test in vitro the reactivity towards the previous donor or a third party. So how can we induce tolerance? So for more than 7 decades, the only pathway to tolerance is the induction of hematopoietic chimerism. So what is chimerism? Chimerism is the presence of the foreign donor blood cells or immune system in the recipient. The chimerism gets its name from the chimera, which you see here, this Greek beast that looks like a lion with a antelope head on the back and the tail of a serpent. So it's actually the emblem of the American Association of Transplant Surgeons. But when I bring this concept to the patient, I prefer to use the example of the tangelo, which is a chimera between the tangerine and the pomelo. It's a bit less scary. Here you can see even on the skin, the example of mixed chimerism. So there are 2 types of chimerism that you need to be knowledgeable with to understand the principle of tolerance induction. One is complete chimerism. This is when the donor, all the blood cells, take over completely the immune system of the recipient. This is the goal most of the time of the bone marrow transplant, because the idea is that the donor cells need to take over completely the immune system of the recipient to help to cure the cancer. So the donor cell help also to basically kill the last leukemia or lymphoma cells. And there's unfortunately collateral damage, which is what we call graft-versus-host disease, where the donor cells then recognize the tissue of the recipient as foreign and start to have an immune reaction. The liver, the gut, the skin. So this is a probably adequate price to pay to be cured from a cancer, but we obviously think that this would be too much of a risk to simply replace medication in the context of transplant. So mixed chimerism seems to be more appropriate, where you have a mixture of the donor and the cells in the recipient. And this actually leads to bilateral tolerance. There is no graft-versus-host disease and no rejection of the organ. The risk of graft-versus-host disease is almost theoretical. And this has been the goal of the Stanford protocol. It is more difficult to achieve than full chimerism because it's an unstable state and needs specific protocol to try to stay middle of the road. So how does tolerance is achieved to chimerism? So you can see in this diagram that the conditioning regimen and the infusion of donor cell leads to this mixed chimerism of cells that are initially tolerated by the immunosuppression. And these cells are allowed now to migrate to the entire body. And there are two parts of tolerance. One is clonal deletion and peripheral tolerance. So the donor cell can migrate to the thymus. And if you remember immunology, you have the positive and negative selection. And now both the donor and the recipient cell are present in the thymus, and the alloreactive or overreactive T cell will be deleted. So you have clonal deletion of the T cell that would produce graft-versus disease or rejection. But this is not sufficient. So these protocols need to increase also the presence of regulatory cells that in the periphery calm down the reaction, the immunologic reaction, and prevent rejection. So who is doing tolerance in our field? There's not actually many centers. In the United States, there are three main centers who have been involved in the development of tolerance. And let me tell you about the difference of this center. So MGH, or Boston Protocol, was the first to start in 1998. And their protocol consists of more kind of chemotherapy and thymic irradiation. And they use bone marrow transplant, but what we could say first generation, basically on manipulated bone marrow. And their goal has been transient chimerism. They have done 10 patients originally around the year 2000, and now they have reinstituted a modified protocol recently. But their program has not been fast to grow because they had to deal with severe humoral rejection and increase creatinine after the infusion, which we now call the engraftment transition syndrome. Stanford followed suit in 2000, and our protocol, which I will describe a bit more in detail, is more mild, and it consists of ATG, which is 80% of kidney transplant patients receive after the transplant, and total lymphoid irradiation, which also explain the difference in a few seconds. Our protocol is post kidney transplant, and we have a second generation of cell product which purified the CD34, the hematopoietic stem cell, and add a specific number of CD3. And we aim for mixed chimerism, as you already heard. And Northwestern program started a bit later. Their goal is a bit different. It's really similar to a real bone marrow transplant, and they have actually achieved complete chimerism, and with a very low rate of graft-versus disease. But unfortunately, some patients have died from graft-versus disease, and that has slowed down or even altered their phase 3 trial that had been started recently. So today, there's only one protocol that is open and continue to enroll patients. And as you can see, we have probably the largest world experience. So the characteristics of our program. First, this program is based on 50 years of basic and translational research led by Dr. Sam Storber. If you do not know who Sam Storber is, he unfortunately passed away 1.5 years ago. He was a rheumatologist. However, he has spent all his career to develop tolerance in organ transplant and reduction of graft-versus disease consequences in the bone marrow transplant. How did he get that inspired to do this? He was actually a medical student in the lab of Joseph Murray, who had performed the first successful kidney transplant and devoted the rest of his career not to rheumatology, but to the advancement of tolerance. And all this started in mid-70s when he demonstrated that the combination of total lymphoderadiation and anti-lymphocyte therapy resulted in stable mixed chimerism and graft tolerance in the mice. At that time, most of the protocol were using TBI and led to graft-versus disease and death of almost all the animals. So what is TLI? TLI is also an invention at Stanford. So Dr. Kaplan, who is basically the father of modern radiotherapy, developed this therapy where the radiation is focused to the lymph node. That's, you probably remember this, the T inverted Y target for the treatment of Hodgkin disease, which was extremely successful. Now this has been replaced by medication, but the TLI has been used in our tolerance induction protocol because it is not myeloablative, but rather modulate the immunosuppression toward a tolerogenic effect. TBI is the irradiation of the entire body and leads to depletion of the bone marrow. And if the dose is sufficient, it could be considered what we call lethal. So which means if you do not receive a bone marrow transplant, you will die in aplasia. So that's the only immunology side that you'll see today. So how does this work? So Dr. Strober have defined this very well in multiple experiment in animal model. So the TLI reduce the number of lymphoid tissue, which go to apoptosis, and they're engulfed by these dendritic cells, which then become tolerogenic. And through the signaling, including the PD-1, which is actually the opposite of what our colleagues from oncology want to do, stimulates activate the key cell, which is the NKT cell. So they're not NK cell, but they're the family of T cell, tolerogenic, produce IL-4, in which in turn induce MDSCs and Tregs to produce their immunomodulatory cytokine, which prevent rejection and graft-versus disease. So the other two characteristics of our protocol is, as I mentioned, we have a second generation of cell product, which separate the CD34 than the T cell. Why are we doing this? The T cells from the donor do favor engraftment. They go and, in a way, fight for the donor for niche in the bone marrow. So if we want to target mixed chimerism as opposed of full chimerism, we need to be able to titrate exactly what is the amount needed to hit middle of the road. And also in his wisdom, Dr. Strober has modeled the protocol to be done entirely post-transplant. The two other protocols are done pre-transplant and thus not really applicable to the field of deceased donor transplant. So if everything is done after the transplant, when we do not know when would be the date of a deceased donor transplant, this will make this protocol the only protocol applicable in that setting. So this is the progression that we have done clinically. So we have moved clinically actually in 2006. 6 experimental patients were done first. And it's only in 2005 that we got the NIH grant to be able to enroll more patients. As we have moved from better match patient to less match patient gradually as we gain experience. Just for you to remember, HLA antigen are a source of sensitization and rejection. If you're identical twin, you don't need anything. The best next thing is being HLA match, which means all these HLA antigen are the same. And the chance of having this is 25% between the siblings. So it's a very small number. Haplotype match, then it's half match, 50% of brothers and sisters, and all parents to child and child to parent. And most transplant now living donor are from unrelated patient, and then this will be less than haplomatch, and that's what we expect the matching between most living donor transplant now. So what do we need from the donor in addition to the kidney? So the donor need to provide the stem cell. So it's a peripheral mobilization, which is exactly the same as they use in bone marrow transplant, and they do about 400 to 500 of these cases, if not more, on a yearly basis. Basically, patients receive GCSF, which is the hormone that will help the bone marrow cells to divide, to the point that they spill out from the bone marrow in the circulation, and they can be catched by this pheresis machine and collected in this bag. Then what we do, we proceed with the separation of the CD34 cell, and the CD3 are kept to be dosed to according to the protocol. One thing that is important to note, the CD3 are not purified, so they're just the amount that will remain in the bag, including other immune cells. We do this about 4 to 6 weeks before the transplant, and then the donor participation in the study is limited to this additional step. This is the schematic representation of what we do with the recipient. So again, the kidney transplant goes in first. It's usually done on a Monday. The patient receives a daily dose of ATG, which again is almost standard in transplant. And then they start on Tuesday their total lymphoderadiation. The dose is relatively small. So Dr. Kaplan used 5,000 to 6,000 centigrade. We use 1,200 centigrade. And this is started during the hospitalization. The patient are discharged on Friday. They come back the following week to complete the radiation as outpatient. And when the radiation is all completed, then they receive the cell preparation that has been prepped for them and then thaw at bedside. And it's just similar to a blood transfusion. This is done at the ITA, and it takes less than an hour or two. Then for the HLA match patient, the immunosuppression was steroid 10 days, CellCept only 1 month, and then basically monotherapy of cyclosporin to be reduced to 0 between 6 and 12 months if the patient showed mixed chimerism, no evidence of rejection, no evidence of graft-versus disease. So this is what we see after the transplant. This is what we monitor. Can we look at chimerism? Yes, we can. And bone marrow transplant have followed their patient. And what we do here is we actually even separate the cells of the donor in T cell, B cell, just to understand more what is going on. And with the difference in some genes between the donor and the recipient with PCR, with the short tandem repeat analysis, you can actually know if this is 80%, 20% of donor cells. So in this first panel, which actually the first patient we have transplanted, you can see the mixed chimerism. So 100% would be at the top here. So here the percentage of donors. So for example, B cell around 80%. And continuous T cell, which is particular to our protocol, take a long time to increase in number. This is probably related to the irradiation of the thymus, which needs to heal before it can produce more of naive T cells. So the arrow shows where the immunosuppression was stopped, and for that time on, the patient enjoyed a graft function that is normal without immunosuppression. And in this case, the chimerism was persistent, which happened about 1/3 of the patient. Most patients actually, after the cessation of immunosuppression, lost their chimerism, but did not lose the tolerance to the kidney transplant, with the exception of 2 out of 16 patients. So what are the outcomes? So we transplanted 29 patients, 28 were infused, and more than 80% of the patients were successful in terms of engrafting and then withdrawn of immunosuppression. To this day, and that's up to 16 years, about 68% of the patient remain off immunosuppression. 5 patients had to be put back on immunosuppression. The 2 patients that I mentioned that broke tolerance, it was only a slight increase in creatinine. We did a biopsy, mild rejection, and they were returned to standard immunosuppression. And 3 patients had to be put back on immunosuppression due to the recurrence of kidney disease, which we thought could be advantageous for them to have some degree of immunosuppression. And 5 patients were maintained immunosuppression because they did not meet the criteria to be withdrawn from immunosuppression. So we did biopsy at the time of taking off the immunosuppression and also 1 year or more later. So out of the 24, 22 patients got these 2 biopsies, which are absolutely pristine with no evidence of rejection. We have also demonstrated that these patients are unresponsive to the donor, but not to third party. And these cellular reaction assays are difficult in HLA patients, so they have to be done with dendritic cell of the donor, but specialists of the lab of Dr. Engelman were able to do these studies. So you can see here that, for example, the patient responded immunologically the cells to the donor before the transplant, but when the drugs were stopped, no more reaction, but they were still able to react against a third party. And they also were able to respond before and after the transplant to stimulation, to previous antigen stimulation. So if you remember that the operational criteria of tolerance, so these patients have no evidence of destructive immunologic effect in their graft. The tolerance is unresponsive is specific to the donor, so they meet the criteria of tolerance. So now, what's next? So are these protocols, only available at center like Stanford? Is it like something more boutique, or it can actually be expanded and benefit more patients? So investigators from UCLA, Zurich, Tel Aviv have actually reproduced locally our experience. We share with them our protocols, and they were able to transplant their patient and to be very successful. So to my knowledge, 17 patients have been transplanted and 16 are off immunosuppression, so almost better than us. Also, the small pharma, Meteor Therapeutic, licensed IP from Stanford to run a phase 3 trial evaluating the Stanford protocol at a large scale in more than 16 centers. So 30 patients were enrolled, 20 on the treatment group and 10 controls. And they also achieved the similar result that of 80% plus. They are almost done with the protocol, and they're seeking FDA approval for a BLA in 2024. So this demonstrates that this can be exportable. And it's also very reassuring that even most of these centers have done 1 or 2 patients, and they were successful right away with the same degree as we are. And it does prove that even something that appears complex, if you're given a protocol that is mature and you have the support, this can be done. So if Meteor gets the FDA approval, then I think it's a major step, because it will be the first tolerance protocol that could actually be available at a center near you, and insurance company would have to support it. So when, in 2010, with the initial success of our HLA match patient, we decided to move up the ladder in terms of difficulty to transplant and more immunogenic difference. And we started the haplotype protocol. And we knew it was going to be more difficult, and the engraftment would be more difficult. And we thus had 2 steps. One was to demonstrate that we can achieve mixed chimerism that would last at least 1 year based on our experience of the HLA match. And the tool that we had, as mentioned before, is giving more T cells. So the HLA match patient received only 1 million per kilo of T cell, and then we add a plan dose escalation until we reach the desired outcome. And then if the patient would achieve, then we would proceed gradually to the reduction in immunosuppression, 1 year for MMF and 1.5 years for tacrolimus. So the protocol remained essentially the same with the exception of this dose escalation. Again, the matched patient required only 1 million of T cells, and we had to increase from 3 million to 150 million of T cells. The immunosuppression was prolonged as I mentioned, and the criteria for reduction remained the same. So this is a busy table, but basically it shows the outcome of all the 27 patients that were involved in this study. In the first column, you have the CD3 dose escalation, as you see, going from 3, gradually going to 150. The chimerism is in the following columns, and just to make it easier to see, blue means good. Blue means that they have achieved the criteria of 1 year of chimerism. As you can see, the distribution is relatively random, and it is not proportional to the dose escalation. So even if you look at the degree of chimerism, you remember that the panel that I showed you for the match, it was close between 60–80%. And you can see these are 9 of the successful patients, and with the exception of patient 9 and 10, the chimerism is much less, and you can see that it also starts to wean off or wean down even before reducing the immunosuppression. So if we go back to our goals, out of 27 patients, we achieve mixed chimerism of 1 year only in 11 patients. However, if you withdraw them from cells, from MMF, it was successful, and all patients were withdrawn without loss of chimerism. And some patients got biopsy and they remained pristine. But the story was not the same when we tried to pull the plug on tacrolimus. And 8 of the 11 patients actually lost their chimerism. 3 of them had reversible episode of rejection. So this is different than what we have seen in the HLA match, where rejection was not seen after loss of chimerism. So this, we put a halt to the reduction of immunosuppression and reinstitute immunosuppression of patients who have lost chimerism to prevent further episode of rejection. So three patients that had still chimerism that was less than 20% were now maintained on a single drug, tacrolimus or MMF, up to 6 years. So you can see that is an incomplete success. You have some patients that can go to monotherapy, but we have not achieved sustained mixed chimerism or tolerance. And the T cell dose escalation, as opposed to what's been shown in the abdominal model, did not influence the engraftment. So we did have to make a change of the protocol to enhance the hematopoietic engraftment. So we are entertaining 2 different modifications. And one is to increase the intensity of the conditioning regimen. And you remember, we talked about the difference between the TLI and the TBI, and we thought that a small dose of TBI may be actually useful by creating a little bit more space and favor the engraftment. So this has demonstrated first in the animal model, and Dr. Lovsky here of bone marrow transplant has demonstrated the safety of this approach in similar protocol that they use in bone marrow transplant. So we felt ready that we can expose our patient to this protocol. We also entertaining modifying this cell product by adding these T regulatory cells to the mix to see if they would favor engraftment. So this protocol, which is actually a collaboration between Northwestern and UCSF, is less mature, and I will not have time to discuss the result today of this one. So this is what we have seen. The first patient actually flipped to full chimerism. So this patient developed graft-versus disease, which was very mild. Skin lasted 3 months in remission, and now has been about 3 years of all immunosuppression, no chronic graft-versus disease, and of course, she would have no rejection of the kidney. So you can say this is our most successful patient in the mismatch protocol. However, the outcomes of graft-versus disease cannot be predicted, and it's possible that it could be worse other patients. So we preferred at this point to de-escalate our intensity of the protocol and still aim for mixed chimerism. And this is the outcome of the following 4 patients after reducing from 80 centigrade to 40 centigrade of TBI and reducing the cell dose of the T cell from 150 to 50. So you can see high mixed chimerism that is sustained. You can see that this is more straight lines. So patient 3 and 4 are almost within 1 month will be off immunosuppression. So these are likely to be the first successful mixed chimerism patient. Patient 2 here lost partial chimerism when the tacrolimus was stopped, and now we are maintaining this patient only on a low dose of CellCept, which is non-nephrotoxic. This patient here is off tacrolimus and maintained on CellCept because of the recurrence of a C3 nephropathy that needs that medication to be kept in remission. So if we compare the effect of the TBI, the single dose, to the previous patient receiving only TLI, actually the most successful of the group, the 11 patient that made it to 1 year, you can see in blue compared to red, a clear improvement in the engraftment in all the cell lineage. So in a way, what's next? As I said, most patients don't receive living donor transplant from family members, and unrelated transplant constitute the majority of transplant. Could be friend, could be spouse. And we consider that now with the success of the TBI, that it was the appropriate time to expand our protocol to the mismatch patient. So this is the outcome of the first 4 patients that we have done. At 40 centigrade, this patient had no engraftment. So we moved up the dose to 80 centigrade and have a little bit of a response on this patient and a little bit more, certainly more on this patient, but not sustained. And this patient had a better match. So per our protocol, we increase the dose to up to 100 centigrade on the very mismatched patient. And you can see the TBI has been successful in creating a significant engraftment. The problem is that after 2 months, the donor hematopoietic cells were rejected by the recipient in a quite vigorous way, which led to this transition syndrome that we have described with increased creatinine and some cytopenia, which took more than 2 months to recover. So we can see that the TBI helped engraftment, but did not help in these patients to maintain the chimerism. And another solution, as opposed to increase further immunosuppression, needs to be put in place, and that's what I'll discuss in the next slide. So for the haplotype patient, I think we have achieved the right dose in the protocol, and what we need to do is to enroll more patients and see how many of them we can go to complete immunosuppression. Less than haplo, the task is more difficult because of this graft transition syndrome. However, we're fortunate to work with our bone marrow transplant colleagues who also are involved in innovation in their field. And a company called Orca Biotech, which is a spin-off of Stanford, is developing for bone marrow transplant, 3rd generation of engineered graft that actually have resulted in reduction of this graft transition syndrome from 50% to 1%, and in full engraftment, graft-versus disease from 15 to 40% to only 5%. So we are our colleagues for BMT were able to negotiate with the company and allowed us to explore the effect of this engineered product, ORCA-Q, in the setting of the mismatched patient. And we are thus in IRB review and IND review to be able to eventually, hopefully in the next couple months, evaluate that product. So all these patients participate and hope to improve their care. What is the risk that they are taking to participate in protocol that actually trying to get medication off? So if you compare the survival at 1 year, 1% survival in 66 patients enrolled in this protocol, and at 5 years, compared to even US at 3 years, also remains favorable. We have seen death, but these appear to us to be non-related to the protocol. 3 sudden death, cardiac arrest, morbid obesity, pulmonary embolism, and 1 patient late death 10 years from a severe lupus that recurred. There were 5 graft loss, most of them due to recurrence of disease, with the exception of 1 with chronic rejection, which I'll discuss in 2 seconds. And rejection, we have discussed all these 5 patients already for matched patient. Basically, when we try to reduce the immunosuppression, the people who fail might have mild rejection, but we're following these patients very closely, and all these episodes have resolved. In the mismatch, it's been the same, with the exception of 1 patient with non-adherence, and now he is more adherent to the program, has excellent graft function, and we did change the immunosuppression for a lower intensity to allow the pregnancy in the patient, which led to the rejection years later. We have 1 case of graft-versus disease, and surprisingly, bikini nephritis is actually seen quite frequently in kidney transplant associated with high immunosuppression, and we have seen none in our protocol. Basically, the only signal that we have seen is shingles, herpes zoster, which was quite frequent, is related to the radiation, and has completely disappeared if we prolong the prophylaxis up to 2 years. Hospital stay and readmission, pretty similar to standard of care. So what does it mean for our patient? We have not done quality of life evaluation of our patient, but our colleagues from Boston have done so. And when they compare their tolerant patient to controls, they see less medication for high blood pressure, no medication for diabetes or dyslipidemia, and they do score better on quality of life or health survey questionnaire. They're less likely to experience depression, dyspnea, excessive appetite or thirst, flatulence, hearing loss, itching, joint pain, lack of energy, muscle cramp, and lack of libido. And talking to our patient, they love not to have to take medication. So what does it mean for the system? We have our team in renal department have done the cost analysis of our 2 haplotype match, looking only at the difference in savings on immunosuppression compared to all the costs involved doing the radiation, the cell therapy, the monitoring of the chimerism, and as this has resulted, depending on the age you're transplanted, to savings up to $100,000. So if all the patients during that time period that had the HLA matched patient, which is about 5,000, the global saving for the system would have been close to half $1 billion. And this does not take into account the comorbidities. And we expect that if haplo or mismatched patient would be tolerant, the saving would be greater because they take more medication. So A well-kept secret here is that I've talked about kidney, but actually there has been a liver tolerance protocol. So Dr. Bonham and Dr. Sorber developed a deceased donor liver tolerance protocol, also in the around 2005 or 7. The idea was that the liver is a hematopoietic organ and can bring its own donor cells, and maybe only the tolerogenic effect of the TI would be sufficient to achieve tolerance. We can even, if you measure randomly liver transplant patients, 5 to 10% have transient chimerism. So they enroll 10 patients receiving the TLA-ATG, and 6 were actually weaned off immunosuppression. Unfortunately, some patients develop severe hepatitis C recurrence, and some patients also have recurrence of their hepatomas. This was an era before we were able to treat the hepatitis C. And so we expect Dr. Bonham to resume his protocol in this new era soon. So what if you already have the transplant and want to stop your medication? Well, we have a study for this, which is a STOP study. So the study of tolerance of organ previously transplanted. So if your donor is still available, you can collect the cells and just apply the protocol as is and achieve the mixed chimerism and basically apply the same process. So this has actually may have actually some significant advantage, including the fact that the cohort of patients is larger than patients that are transplanted on a yearly basis. But also, it is unlikely that 250 transplant centers in the United States will be able to provide tolerance induction protocol. So if you do it in the delayed fashion, you can have your transplant at your local center, you recover, and then you can be referred, if your donor is available, to expert center that will then achieve tolerance. So we actually had the IND approved and the IRB approved since 2017 for the match patient. And now we are waiting the review of the IRB to move also to haplotype match. We have one patient consented, and we anticipate the transplant this month. Deceased donor tolerance. So most transplant patients receive their organs from a deceased donor. So if you can see the data here in blue, this is the living donor transplant. Even kidney transplant is 5 compared to 20,000 in all the other organs. So the protocol was designed to be able to address this issue, and we have been able to come around to it. So what we need is the donor stem cells, and we can obtain them from the vertebral bodies. And this has been done in the 90s and in hundreds of patients, but without the intent to create chimerism. So we have actually improved the manufacturing process. Dr. Lovsky has developed the IND, the IRB has approved it, and we're thus basically ready to go. We have already one patient enrolled. So then you'll say, well, that's one patient out of many potential patients that can receive an organ from a deceased donor. So limitation is that even with optimized manufacturing, we can only have enough stem cells to do one patient. So can you expand stem cells? So actually, it's a great focus of interest in the indication for bone marrow transplant and gene therapy. And there's this molecule UM171, which actually is one of the lead molecules that maintain the self-renewal capacity of the stem cells. This molecule is already at the clinical stage of investigation, and it's used in cord blood where the amount of stem cell to do a bone transplant is too small, and then it can be expanded and result in excellent graft outcome. So can we use UM171 for deceased donor bone marrow expansion? Of course, it's not on the radar of the bone marrow team. However, UM171 stands for Université of Montréal 171, and the lead scientist Guy Sauvageau happens to be a hematologist in Montreal, a colleague of my twin brother, hematologist. So over the years, we have entertained some conversation and piqued their interest in developing these expansion in the context of tolerance. We have recently shared a sample of our bone marrow product that was obtained during our manufacturing process, and they were able to expand 20 to 30 fold. So this is very promising. As you can see, you can serve more than one recipient, but you can also imagine that if you have enough, you can actually have enough to redose the patient in the future. So in conclusion, are we there yet? So HLA match, I think you have arrived. It's a mature protocol. The results have been reproduced outside of Stanford and could rapidly become standard of care if FDA approved. Haplotype match, your destination is in view. We're almost there. The recent refinement of the protocol have really make a big difference. We need to do more patient. We need to test the tolerance. And even if we have half of the patient, 1/3 of the patient remain on one drug, it's already a acceptable, better outcome than the standard of care. Mismatched patient, deceased donor, well, that will take a little bit more time, but we have, I think, all the tools to move forward. And that's one thing that I would say is uniquely Stanford. And as you have seen, the contribution of this multidisciplinary team with innovation that is happening here. So we are standing on the shoulder of giants, and the giant is Samuel Strober. And has basically built this huge team that will be able to pursue his vision of tolerance. And as you see, this is really team science. And it's not only interdepartmental, it's across department. Surgery, nephrology, BMT, pathology, radiation, and of course, the basic scientists that do the correlative studies. Dr. Strober was able to get almost ongoing fundings for 20 years, and for the NIH, the CERM, and we also benefited from the help of the hospital. And recently, Dr. Meyer was here, was able to convince the Department of Medicine to invest more in this program. As with the regulation, it is impossible to use the original model of a few PIs and a few coordinators. We need a stronger structure. And with the help of Dr. Ahn, we're able to support the structure provided by the Stanford Center for Clinical Research with management and expert coordinator. Also, our clinical team, for instance, Stanford, and I see Sui and maybe others in the room or online, who actually contribute to the advancement of this research. And probably most importantly, our pioneer patients. So I would leave you with this quote from Sam Strober: if we were able to make organ transplant a reality in the 20th century, the goal for the 21st should be to do it without drugs. And I would add to this that it's likely to happen here. Well, thank you very much.